Hello and welcome everyone. My name is Richardson-Gool and I am your host for this Cov360 live event in collaboration with World Without TB. Today we are holding a meaningful conversation on an area outside the COVID-19 headlines, but very much relevant to the ongoing pandemic. This evening we are discussing neglected diseases, tuberculosis, HIV, and Cryptococcus meningitis. We are joined by a wonderful panel, rich in expertise and experience from around the globe concerning these neglected diseases. The panel will take your questions from around 40 minutes past the hour after our initial discussion. But before we embark on that discussion, may I just introduce the fantastic panel that we have with us today. First, Professor Amina Jindani, the scientific advisor and founder of the partner organization for this event, World Without TB, a professor in Tuberculosis Therapeutics at St. George's University, London. She will share her experience with her charity and expertise in TB. Then Dr. Nadia Ahmed, who is a consultant in HIV and sexual health medicine at Mortimer Market Centre and University College Hospital, London. She explains where we are with HIV and her thoughts on a patient-focused approach. Thirdly, it gives me great pleasure to introduce Professor Tom Harrison, Deputy Director of the Institute for Infection and Immunity and the lead for the Centre of Global Health at St. George's University of London. He will explain more about cryptococcal meningitis. But first, Tom, I want to turn to you with a broad question, speaking to you as the Deputy Director of the Institute of Infectious Diseases. May I ask you, considering the global impact that COVID-19 pandemic has had, how has this affected other areas and preventative treatments concerning infectious diseases?
Thank you, Theo, for this. Yeah, I mean, I don't think it would surprise anyone to say that, the COVID pandemic has had a huge effect on other services and the delivery of services and research into other infectious diseases. I mean, our own experience in South London during the first wave in March and April, I mean, essentially St. George's Hospital was taken over by COVID. And the other services were largely suspended, and certainly all other research was suspended, so that all our research efforts in the hospital were focused on COVID. So that was really an extreme situation. I mean, now during the second wave, it's a little less drastic. We've got numbers of patients building up on the wards, but the ambition is to keep other services going, because obviously other infectious diseases, other urgent medical conditions just don't go away because COVID is with us. So no doubt there's been a huge effect of the pandemic on services here in the UK, but on top of that, we think, I know myself and I know Professor Jindani, we're involved in research efforts globally. So obviously there's been an effect internationally as well. And, our research studies, my own group's research on meningitis, Amina's TB studies, I mean, we suffered virtually a pause, or an almost total pause in recruitment into our research studies because of COVID. For, I guess, in the order of a couple of months. And then subsequently, we have managed to continue studies, but the recruitment, certainly in the meningitis studies we're involved with, has been slower. So, we're recruiting at about half the rate. And it certainly is our impression that actually the participants are more severely ill. So I think, it's an inference, but I think there is the likelihood that patients are not presenting themselves to hospitals so readily because of fears around COVID in hospitals, and also because of practical difficulties of traveling. or restrictions to travel dependent on the government mandates within because of COVID. And certainly, I know there's plenty of data out there. I think there's plenty of data out there that the numbers of patients treated for various other conditions has dropped during this COVID pandemic.
Thank you, Tom. I mean, it's a concern to hear this. And I know that in some ways you're referring to what's happening in the UK, but you, as you alluded to, you work with teams across the globe. I just got a short follow-up question. I mean, we've seen this exponential response to COVID-19, and I believe even reflecting on a conversation I had with Amina back in April, she didn't expect a vaccine to be developed as quickly as it has been. And I think it may have surprised a lot of people. And I suppose these rapid advancements concerning COVID-19 and us being able to mobilize a global response in terms of research, does this offer any insights for your research concerning other infectious diseases? Is there a way that we can repurpose these technologies?
Yeah. Well, I mean, I think there are lessons to be learned, frankly. I mean, I think, for example, the recovery trial that I'm sure many of the people listening into this conversation will be aware of, the Oxford trial of treatment for COVID. It's the largest UK effort. I mean, I think there are lessons to learn from that trial. It's an extremely simple trial in terms of the conduct of the trial. They've really reduced it to a bare minimum of data that needs to be collected and form filling and so forth. And that's really important because it's meant that the trial is inclusive, and I think it's 176 hospitals are involved in the recovery trial across the UK. And that's keeping the trial as simple as possible so that hospitals can participate. For me, that's a lesson especially for our research in lower and middle income countries, because sometimes the complexity of conducting trials actually excludes some centers from participating. So I think for me, that's a lesson. And also, of course, the other thing about recovery and some of the other COVID related trial efforts is their adaptability. So, I mean, that's great, isn't it? The way they've been able to introduce new treatments, rapidly without going through a whole new regulatory and ethical framework. So the way that's been set up so that the trial can adapt over time, I mean, that's wonderful in terms of speeding progress. So I think those kind of methodological lessons are important across medicine, and something we can learn from this experience. I mean, specifically about the technologies in COVID, yes, the vaccines, and obviously I guess we're all excited about the mRNA vaccines. And I mean, that was a new platform that was being researched, but not specifically for COVID, as I understand it. And obviously that's received a large boost with the results from COVID, and one hopes that might be transferable into vaccines for other infectious diseases. So that's some of the lessons. I think maybe lastly, host-directed therapies, because obviously some of the treatments for COVID that are being explored are aimed at dampening down this excessive inflammatory response that the patients get. So this is a host-directed immunomodulatory form of treatment. And I mean, I think possibly we will learn in COVID that those types of treatment do need to be targeted. I'm thinking of the data that's emerging around tocilizumab as a treatment for some patients with COVID. I mean, in my opinion, when you start talking about host-directed modulatory treatments, they have to be targeted to the patients according to individual patient immune status, and it might be that only certain groups of patients will respond to host-directed therapies. And for me, that's a general lesson in terms of host-directed therapeutics.
Fantastic, thank you. That was rich in analysis, Tom. So thank you very much for that insight in terms of what we can do to collaborate within the health sector and what can be done within infectious diseases to further understanding from what we've learned with COVID-19, and indeed, I think highlighting some of those regulatory challenges that do exist with trials and treatments is an important one, and something I believe we're going to discuss a little bit later into the conversation further. I want to take it to Amina to discuss some of the concerns around and the history of TB, because we've made these fantastic advancements with COVID-19, and I think it's been said that TB may even be the oldest of infectious diseases on record. And you established the charity World Without TB, Amina, and your career, I believe, starting in Kenya, has focused on this disease, and which has killed over 1.5 million people per year, if not significantly more. And I would like to hear a little bit about the history of TB and indeed your work, if you can elaborate on that.
You see, the history TB is in direct contrast to what Tom has said about coronavirus. TB has been with us for centuries, if not millennia. And although we have an effective treatment, it has stubbornly defeated all our efforts to eliminate it. And this is largely because we don't have an effective vaccine, in spite of much research being done. In contrast to coronavirus, where the vaccine has come up in months, here in decades of trialing, we have not identified an effective vaccine. So to me, this is a failure on the part of the scientists, not to develop a vaccine. And to me, it seems that they don't take TB very seriously. I may be wrong, but how many pandemics have come and gone, and still TB remains with us? Now, there are several reasons for this. The first is, although we do have an effective treatment, very effective, we've brought it down to lots of groups, research, down to 6 months. But even 6 months is too long for patients to take. And about the 3-month time, they feel good and they stop. Now, and they relapse. Now, recent research has shown that if you miss even 1 dose, that compromises the effectiveness of the regimen. So the answer to that is to get to a 1-dose shot. Secondly, we don't have an effective track and trace. Every national program is told to contact trace cases of patients who present with tuberculosis. But I don't get the impression that it's done in a very focused way. In fact, it's done in a very desultory way, that they're told, well, if you've got somebody at home, tell them to come to the clinic. That is not the way to contact trace. They have to be more focused about it. Fourthly, the pandemic is fueled by the HIV pandemic. The biggest cause of death amongst HIV, people living with HIV, is tuberculosis. But Nadia will tell you more about that, so I won't go into that, but it does fuel the TB pandemic. Lastly, funding for research is woefully inadequate. It takes months to get adequate funding to be able to move from seamlessly from one trial to the next, which we need to do. So if we see some results, promising results in a trial, we need to then seamlessly be able to move to its next trial, but it's not that easy to get the funding. And then the regulations, they're getting more and more complex. And sometimes it takes almost 2 years to get approval to carry out a trial, to approve in a country. So this is why I established World Without TB, to build, first of all, to support research in TB, but better still, to build capacity in those laboratories where I work, which have woefully outdated equipment and sometimes dangerous. One laboratory I worked in, the centrifuge in which they spin highly infectious sputum, the tubes were broken. Now, you can imagine how dangerous this is to people working in that laboratory. So World Without TB was able to provide a new refrigerated centrifuge for the laboratory people to work safely in those conditions. So ours is a small charity with little funds, but I think in terms of effectiveness, it does a lot of good. And I would wish that we could get more support for this charity. So my research is aimed at reducing treatment duration as much as I can, which improves adherence. And as I've told you, adherence is vital to cure. And secondly, to build capacity in the laboratory so they can participate. And as Tom said, the simpler the trial, the better they're able to participate and follow up the patients. COVID, as he said, has impacted these trials in that patients were refused for a time to get on a bus to come to the clinic. But we got over that by sending the clinic team out to their homes to collect the sputum specimens. So, you know, it's not been easy, but we've managed to keep on top of this current trial that I'm doing in Africa, Asia, and in Latin America.
Thank you very much, Amina. I was watching a lecture earlier this year, and I think you were speaking about these trials that you are doing through Interb. And is it correct you're trying to reduce the treatment time from 5 months down to 4 and 3?
It's currently treatment duration is 6 months. The current trial is hopes to identify a 4-month regimen. And already the 3-month protocol is on the drawing board. What we really need is a one-shot treatment, but that's just a beautiful dream.
Well, I think it highlights, I mean, your correction of my, I suppose, underestimate or how I underappreciated just how difficult this is, because as you suggest, you need the compliance and the adherence to be able to take it for 6 months, the treatment, and that is a huge challenge. And then also highlighting that there is not sufficient equipment. And when we consider that this is a disease which affects the global south or developing and low resource countries, that's a critical challenge also. Indeed, you highlighted by email to me, I mean, earlier today, you sent me a message from Stop TB and UN Ops, and they have made a call to the UN Secretary General, an urgent call that something does need to be done concerning TB. I mean, is there something that you want to comment in concerning that connection with COVID-19 and TB and that's of that effect?
Yeah, what the international people are trying to say is during this coronavirus pandemic, don't take your eyes off the ball with TB, because coronavirus with the vaccine will still be left with TB. And as for the effect of coronavirus infection on TB, undoubtedly there will be, but that hasn't become apparent yet in terms of numbers. But undoubtedly it will become. But you know, there's been a curious theory out there by some scientists that maybe TB protects people from getting COVID infection. And they've suggested that people who've been vaccinated with BCG are somehow protected from getting coronavirus infection. But this is only a theory. Nobody has got around to doing proper research. But if that is the case, that will be quite astonishing.
BCG, can you explain what that is to our audience?
Bacille Calmette-Guérin, 2 French scientists that discovered the vaccine called Bacille Calmette-Guérin. It is a vaccine that's been used for tuberculosis for years, for decades. It's given to all newborn. At one time, it used to be given to school entrants as well. But we've since realized that BCG does not protect people from getting the adult form of tuberculosis. So for that, we don't have a vaccine. but it is given to newborns because it does seem to protect them from getting TB meningitis or disseminated tuberculosis.
Appreciate, thank you for clarifying. I suppose as well, the caveat there is that the science is young in the terms of whether we know if BCG is going to have a positive effect or not, but it is indeed certainly an area and research area to explore further. Nadia, I want to bring the conversation over to you and really consult some of what Amina had alluded to as well, where she had raised HIV as another disease which has indeed potentially suffered through this pandemic, but focusing really on how we can understand human immunodeficiency virus, HIV, infected people and why they indeed succumb to the virus. It would be interesting to know more about the fact that this is secondary to TB, the most common cause of death, and indeed, when we're thinking about the tremendous leaps forward we've made with HIV treatment, because indeed it put the world at a stop. I think one theorist had alluded to it as the invisible cloak, because it was so difficult to pin down at an early stage what was happening with this disease. And I wonder what you can comment in terms of the advancements in eradicating transmission from mother to child, and how that can walk us through how we're dealing with HIV globally.
Thank you, Theo. So I think it would be good to take a sort of a general look at HIV and then specific comment on also what you've asked. I mean, I'm biased, I think, in some ways because I specialise in HIV, but I think hopefully I'll be able to show you know, the audience that really biased in the right way. And I do feel it's one of the greatest advancements in medicine. You know, definitely there have been other advancements within cancer treatments, for example, and otherwise. And obviously we're seeing with the advances with COVID. So you mentioned invisible cloak. So back in the 80s when HIV was first about, or when it was first discovered, it really was a, you know, death sentence for one, you know, for want of another phrase. It was you know, equated to death, but really now we've gone to a stage where 30 years on, it's a chronic condition, it's treatable, it's manageable. It's not curable, but it's manageable. It's something where we've got good treatment access to. And also patients are seeing a near normal or normal prognosis to those who are HIV negative. There are very small cohorts, for example, that even show patients who are HIV positive could live longer than HIV negative patients. Very small cohorts, you know, I want to stress, but one of the theories around that is that they are seeing a doctor regularly. You know, we would screen for cholesterol, for diabetes and so on, and able to give advice on other things and refer on. So we have really made a lot of progress within the field of HIV. I think taking it a little bit of a step back to looking at epidemiology, which is important to understand where we are, where we're at. There have been, you know, a positive advancement. So globally, we are seeing less infections of HIV. So, you know, the prevalence is going down. New infections are also going down. Men are slightly more affected than women, and over, you know, just very slightly, but also girls, young girls particularly, we're seeing a rise in that, and I'll come back to that in a second. The main population groups that are affected are men who have sex with men, followed by sex workers. They're the highest risk for HIV because of the routes of transmission that are possible there, but also through, you know, more partners as well. With AIDS, so AIDS is your end stage or advanced stage of HIV infection. So HIV is the virus that gets into the body, but when you're, you know, when it advances and it goes to a severe stage where your immune system is very severely affected, you then get AIDS, and it is still treatable at that stage. So you can still go back to, you know, maintaining treatment control and so on. So it is still possible, but we're also seeing a decline in AIDS deaths as well as AIDS diagnosis, and they're very specific conditions that are associated with AIDS. Again, men are slightly more affected than women in that sense. If we look at the countries specifically, so globally we are making gains within sub-Saharan Africa, as well as you know, the west of Africa, Central Africa, Europe and North America. We're definitely seeing improvements there, in Asia. Where we are seeing rises in HIV are Eastern Europe, Central Asia. Combined, it's about 72% increases in new infection. and also Middle East and North African networks, or areas rather, as well as Latin America. We're seeing slight increases in infections there. So we have made progress, and I don't want to, you know, be all gung-ho and say, you know, we've definitely, you know, we're winning, but we are still seeing new infections. And a lot of that progress that we've made is because of antiretrovirals, which I'll come into next. So antiretrovirals are there to treat HIV, not cure it, but treat it and make it a manageable condition. But also testing. There's been a lot more of a drive for testing patients, and you know, that just needs to be built, you know, built in routinely nowadays. I mentioned men are slightly more affected, but in sub-Saharan Africa particularly, we're seeing many more young women, particularly adolescents, being you know, diagnosed with HIV, and it's very disproportionately affected. We're seeing this youth bulge that's happening globally, but particularly affected by sub-Saharan Africa. So there's a big drive, you know, within the sub-Saharan African countries to really focus on adolescent women and to get them testing, but also look at other strategies to try and reduce their risk. PMTCT, so that's mother to child transmission, you mentioned, again, we've made really good advancements there. So nowadays, if somebody's on treatment and they're controlled with a virus, and I'll come on to what that means in a second, and they're pregnant, they can actually have the baby naturally if they are on treatment and they're controlled. So previously, cesarean sections were advocated for, but you can have the baby naturally nowadays. And some countries have managed to eliminate mother-to-child transmission. If you really think about it, it should be something that should be eliminated, such that we don't see child infections from, you know, vertical transmission. So most recently, Sri Lanka has gone onto that list, but prior to that, Thailand, Malaysia, and the Maldives as well. So all 4 of those countries have reached 0 transmissions vertically. I think moving on to treatment, you know, we've really made great advances with treatment, and that has added to, you know, well, it's the main reason for our success with getting the numbers down and getting new infections down. So, you know, back when the drugs were first discovered back in the early 1990s, and, you know, subsequently people were taking up to 20 tablets, not once a day, but twice a day. So that's 20 tablets twice a day. Now we can give a single drug, which is 3 tablets in one. So, you know, that's what is generally rolled out globally now as well, in different formulations and different tablets. So you can go to a single tablet regimen. It's not that it's rare, but it is quite rare for somebody to be on a twice a day regimen nowadays. So it's either a single tablet or 2 tablets once a day. We normally always give, and the standard of therapy is triple therapy, which means 3 drugs against HIV. But actually now we're moving to a dialogue of even giving 2 tablets once a day. There's a lot of data coming around about that. Some people may have seen information about injectables. So there's a lot of, you know, research going into other types of formulations, implants, injectables. Injectables have shown to be done to do very well. And for some patients who particularly struggle with adherence, we've had, Amina mentioned, you know, adherence issues with TB. So adherence with HIV is another, you know, big issue, and this is lifelong treatment that somebody needs to be on, not just 6 months, but lifelong. And yes, it's 1 tablet compared to TB where you're taking multiple tablets. So it's all sorts of different adherence issues with either, but the injectable has pretty much been approved, but it will take another year or 2 before it's fully implemented. Side effects are always something I think people worry about with treatment with HIV, and it's really the old drugs that we don't use, where you see the lipodystrophy, so you have changes in your fat distribution, or, you know, horrendous diarrhea. And the drugs that we have nowadays are, you know, yes, anything comes with their side effect, but it's something that can be managed, or it's something that we can stop and, you know, switch and change. So we've made good advances there. I think finally, well, 2 more points really, is that we do have, you know, nowadays with HIV, the other battle that we are facing. So I mentioned that although we've made those gains, we are seeing many more non-HIV related conditions. So we've got a population of HIV positive patients who are aging. So, you know, as people get older, there's greater risk for blood pressure, cholesterol, diabetes, and so on. So it's about managing that. But HIV itself, even if you're on treatment, you're well controlled, you can still be at risk of kidney problems or, you know, liver problems, but also it can be a risk, for example, for cardiovascular disease as well, so heart disease. And I think the final point to really mention about where we're heading is about transmission. And I think, if anything, to take home from what I just said, it's about transmission. So if somebody's on treatment and they are consistently taking their tablets, they're fully adherent to it, their virus will be suppressed. And when we say suppressed, the other term is undetectable. And from lab tests, that's sort of less than 50. Some labs do 100. In fact, the studies that were done looked at it at viral loads of 100 or 200, so your level of HIV in the blood. So if it's undetectable, it's controlled, you will not transmit HIV to somebody else. So you will not pass on HIV to somebody else. There's been big campaigns around this. So if you're undetectable, you are untransmissible. So that's U equals U. And there's been big studies that have shown this. So the original study showed that there was a 96% reduction in transmission, and it wasn't designed to specifically look at that, but 2 subsequent studies called Partners 1 and Partners 2, specifically looking at if you have HIV positive partner and an HIV negative partner who are together, the negative partner, so in all of those couples that were enrolled in the trial, there were 0 linked transmissions of HIV to the negative partner. There were transmissions that did occur, but it was very clearly related to either that partner having sex outside the relationship or because they had just started treatment. So really, really, big advancements there, and a big message to to pass on and make sure everybody's aware of.
I can see, I mean, that's quite a profound advancement when we consider that we are, in some ways, as you suggested at the start of what you're saying, it's not preventable, but it is treatable and it is manageable, and that potentially for a disease, as you're highlighting, that needs to be treated over a lifetime, tragically.
Yeah.
What can I ask you just very quickly, what type of mortality rate are we considering annually concerning AIDS and HIV?
So it's definitely, definitely less. I think it depends on the regions that you're looking at. But deaths nowadays are more related to other comorbidities. We definitely do see deaths related to HIV, and often that's related to patients that are not on treatment. So not on treatment and have really struggled with adherence. And we do see that there's a lot of complexities with adherence, and the psychosocial aspects of HIV related to stigma can really have an impact on somebody's adherence. So we do see patients that present in those late stages, but equally we are seeing I think more comorbidities. Cancers are particularly rife. So this year with the cohort that I look after, there's been a good few patients diagnosed with lymphomas, for example. So it's really the other diseases that we're seeing, but the death rates are still there, but coming down.
Appreciate it. Thank you very much. And it's interesting to hear these different associated symptoms that you can draw on. And I think speaking to you, Nadia, and also to Amina, it's almost that we're stopping too early when you're laying the foundations of our understanding with these diseases. But now turning to Tom, I suppose an untreated or less treated disease or a disease that gets less attention, cryptococcal meningitis, which actually, as I understand it, becomes fatal when people are contract or have HIV. And I know that this is an area that you specialize in terms of treatments. I wonder if I could ask you about the research that you're doing, and also what are the causes and long-term outlook for the disease cryptococcal meningitis, Tom?
Okay. Yeah, as you say, public eye. I think everyone's aware of meningitis, dramatic infection of the coverings of the brain, clearly life-threatening and not infrequently fatal, but a bit less knowledge about cryptococcal meningitis. But in fact, cryptococcal meningitis is by far the commonest cause of adult meningitis, across large parts of Africa, and due to its association with HIV. So it's a common complication of late-stage HIV infection, and our latest estimates suggest that it causes something in the order of 180,000 deaths per year, and it's responsible for the order of like 15 to 20% of all HIV-related deaths in Africa are caused by this cryptococcal meningitis. It's with TB the commonest complication of HIV that actually leads to death. So the thing is, it's difficult to treat. And across most of Africa, the routine mortality with this infection is in the order of 70% at 3 months. So, you know, people will appreciate probably that's higher than the mortality from Ebola virus infection. And that mortality is despite the commonly used treatment across Africa as of now, which is a tablet called fluconazole, very safe oral tablet, but simply not that effective. And the last thing about the kind of the epidemiology of the problem is that actually the cases are not going down in most parts of Africa. They're going down in South Africa, thank goodness. But despite the availability of antiretroviral therapy and the huge advance that antiretroviral therapy obviously has made, there are still actually patients, either they present late when they've already got late stage HIV disease and they're susceptible to a complication like this, or else there are patients, as Nadia alluded to, who just fall out from care. And the fact is, if just 2 or 3% of your patients in a clinic drop out from care each year, then there's a population that builds up who then represent with late stage HIV infection, with severe immunosuppression, susceptible to an opportunistic infection like cryptococcal meningitis. So it's an ongoing challenge, and it's the fact is the availability of such an effective treatment like the antiretrovirals that Nadia is talking about, it means it's really a tragedy if these patients die of their meningitis. If we can bring them through their meningitis, then they can start on the antiretroviral therapy or restart on antiretroviral therapy and have the excellent long-term prognosis that Nadia talked about. So our work really has been trying to improve this mortality from the meningitis. And so we've been doing series of small phase 2 trials and then larger trials, trying to optimize the treatment and trying to just give you a feel in a nutshell. As I say, the common treatment in Africa is this fluconazole, not very effective. The international gold standard treatment is an intravenous drug called amphotericin B, given for 2 weeks, and flucytosine, a drug which isn't available currently in most of Africa until very recently. And the trouble with amphotericin B, it's intravenous. It's also a toxic drug that needs very careful blood test monitoring that's very challenging in many African centers. So we focused on trying to develop new regimens of those 3 drugs, optimizing the doses, optimizing the combinations, optimizing the duration. And essentially what we found in a large trial that finished just a year or 2 back was that if you give the amphotericin for 1 week instead of 2 weeks, it's a lot less toxic, it's less side effects, but you still get the full efficacy. And in addition, if you give it with this drug flucytosine, you can reduce the 70% down to 25 to 30% mortality. So that's one regimen that's now become established as the WHO's preferred treatment. And on top of that, we've tested the oral combination of fluconazole at a high dose plus the flucytosine, which is also an oral tablet. That also is a very effective treatment. So these are now the treatments following the trial results. It was called the ACTA trial that was done across sites in Africa that have been recommended by WHO and are now being implemented. And actually, gratifyingly, the mortality rates in routine care are dropping, particularly in South Africa, where they've managed to get the flucytosine that they need to use these regimens. Flucytosine is a drug that wasn't available, but because of these results and advocacy efforts, there's large generic drug manufacturers are now making flucytosine, so it is becoming available across Africa. So we're hoping that the mortality rates can be reduced and more of these patients will survive, and then, as Nadia says, go on to get on to antiretroviral therapy and lead long and healthy lives.
Thank you very much, Tom. I mean, it's hopeful to end on that note, and you highlighting that we are currently at a rate where the mortality rate is very high, 180,000, but there is hope that there will be a reduction in that with the wider availability and adherence to the antiretroviral. So there is also one other thing that you mentioned there, which I think is very helpful for everybody in the audience here today, is you had highlighted that CM alongside TB is the commonest combination and cause of death with HIV. And it shows why we are here today talking about these three neglected diseases and why they're relevant to one another. And indeed, it allows us to elaborate on the conversation. I'm mindful of time, and we also should invite the audience to do leave your questions there. I'm going to, whilst we wait for some questions to come in, Amina, I want to turn to you as we consider this ongoing challenge that you deal with concerning TB, and indeed some of what Tom had mentioned earlier, which concerned consent and regulation that we might have learnt through the treatments concerning COVID-19 and how that can be expedited potentially. And I appreciate that you, as we alluded to earlier, are involved in ongoing treatment trials to reduce the time. And what I want to understand and ask you to elaborate on a little bit is what type of regulatory mechanisms do you have to overcome to give us an understanding of the challenges you face as an immunologist working in this area?
You know, when I listen to Nadia and to Tom, I am so jealous because in their areas, they seem to be making enormous progress. Now, in the HIV patients are doing so well. WHO recommending the treatment developed by Tom and his group. In TB, we seem to have stuck and stopped still for about 20 years. Nothing seems to have happened. And yet this is the most deadly infectious disease there is. And not only is because we don't get the funding, but as I said, the regulations in the country where this disease, they have a very high burden of disease, to me, they're getting more and more complex. More and more groups who want to be asked for approval. There was one regulatory body who wrote to me to say about a trial that I had put to them, the safety of the patient is paramount. Well, nobody would dispute with that. Safety of the patient in a trial is paramount. To maintain that safety, the ground around the clinic should be cut from 3 meters from the clinic to prevent them getting bitten by snakes and rats. Now, I ask you, you know, with those kind of regulations, they're just using the trial to clear the grounds of the hospital. We're not going to make a lot of progress, if any progress. For many, many years now, the annual incidence estimated it remains at 10 million and will continue unless we change our mindset. And the annual mortality, unlike the mortality of HIV and Cryptococcal Meningitis, is not changing. It remains between 1 and 2 million. And this is a curable disease, entirely curable, unlike HIV, unlike Cryptococcal Meningitis. So unless the mindset of the regulatory bodies in those countries changes to facilitate the trial going, I'm sad to say, nothing will, this TB pandemic will still be with us long after the coronavirus pandemic has gone.
Thank you. I mean, it's very sad to hear you say that. I know with World Without TB, your target is the eradication by 2050. And I suppose that gives us all an appreciation of how challenging it is when we consider how quickly, and please.
It can be done, Theo. It can be done.
Yes.
As I said, we've got 3-month protocol now ready to start, and the 2-month protocol is already germinating, and it can be done. But I have to have the funds seamlessly, and I have to have the regulatory bodies on my side.
Indeed. And I think, actually, I mean, if we turn back to what Tom started with and what we'd learned with COVID-19, and indeed more recently with cryptococcal meningitis, where the regimen, that is the number of people involved in these trials and the frequency in which we're actually going through and modulate in terms of the amplification, the amplitude of the treatments that are offered, may highlight methodologies that we can embrace and hopefully apply in TB, if I interpret things correctly here. I do want to here again remind the audience, please do leave your questions. We got one point that I wanted to finally raise with and turn with Nadia, and I think it's something that can be embraced across infectious diseases and indeed more widely in terms of how people are treated. Nadia, you've worked in many areas around the globe, and as has Tom and Amina, and you raised the point of patient-focused approaches, Nadia. And I understand that one aspect of TB which resonates with HIV is that adequate resources invested in both diseases are treatable and preventable. But given your expertise as a consultant working in the NHS in London and experience in South Africa and Malawi and Iraq and Iran, what is indeed needed to improve public health promotion to treat HIV and even COVID-19, where maybe there should be a more patient-focused approach, Nadia?
Thank you, Theo. So I think with my first sort of discussion, I painted very much a positive side of HIV and the advancements that we're making, but I do still want to stress that there is still much more, much work to still do, particularly in certain regions. So I mentioned that there has been an increase in Eastern Europe as well as the Middle East, North African areas, but also within Sub-Saharan Africa. So although we are making progress, and also, as Tom has mentioned about cryptococcal meningitis, going from fluconazole to liposomal amphotericin, so that's what we use first line here in the UK, and it breaks my heart slightly to know that we are still having to use fluconazole, but it's great that we're also changing the dialogue there with the treatment that's available there. And I think what it comes down to, and I think all of us have touched on that, is resources and funding. It does become a little bit of a fight for the funding and the money, but we need to maybe think about where does it really need to go. And I think that's one of the things. As you said, HIV is preventable, definitely. It's treatable. It's not curable, but it's treatable. A cure I haven't touched on, but some people even say that if you take a pill a day, you're controlled. It doesn't, it's not transmitting. Is HIV technically functionally curable? And I think that's maybe a talk for another day. But it can be. We do have the options to prevent and to treat, and so we've got the tools and we've got the means. But we need to ask ourselves what's stopping us really, and how can we tackle that, and how can we approach it? And I think if we look at prevention first, you've got abstinence, fine. that is one option from sex, or the other risks. You've got behavioural modifications or behavioural strategies, and that's looking at high risk behaviour. Some patients do have high risk behaviours, and that can be discussed so that people are aware of the risks that they're taking. There's condoms, of course, but there's also PrEP, so pre-exposure prophylaxis. So this is taking a tablet before you have sex to prevent HIV. And similarly, there are tablets that you can take after having sex if you think you've had a high risk event of acquiring HIV. STIs, are sexually transmitted infections themselves, can increase the risk of HIV as well. On the treatment side, there's antiretrovirals, which I've mentioned. There's lots of options available. But I think to address it specifically, I think we need to, it goes back down to basics, that one size doesn't fit all, and everyone is different. It sounds really obvious to say that, so we really do need more patient-focused approaches, and to really tailor tailor treatment towards patients, but also, for example, with the prevention, you tailor what's most appropriate. If somebody doesn't want to take a pill for prevention, talk to them about, you know, their high risk behaviours potentially, or condoms, etc., etc. I think the unique angle with HIV and why, you know, we would say, and, you know, similarly echoes with TB, is that, you know, there's that physical impact, but it has such a massive psychosocial impact on some patients. And in fact, a lot of patients, I would say the stigma, not only with HIV, but with TB as well, it is really rife. I mean, I saw two new diagnosed patients today. One was absolutely fine, understood it, got it, no issue. The other one, I spent most of the time talking about, you know, the impact of HIV for her, and, you know, that mental health impact for her. So stigma is a big issue. But to specifically address it, I mean, I think there's a couple of things. You know, I'm an HIV specialist. It exists as a specialty, I think, only in the UK. We also specialise in sexual health. I've always felt strongly that, you know, it is something that should be developed elsewhere, particularly more the sexual health side, because HIV goes slightly hand in hand with sexual health, and there's that increased risk if you have STIs. But also, and this is a, you know, a small example, in, you know, sub-Saharan Africa or the other countries that I've seen, observed, or visited or worked in, you know, for example, condoms, something as simple as condoms, they're given freely, but they won't have, for example, the variety of condoms. So, you know, it's just one size, but, you know, to actually fit somebody appropriately with condoms, education is needed there, and discussion around what is the right size or what's the right condom for somebody. It's a, you know, very simple example that, you know, in the UK, people are able just to buy condoms, or even get different sizes or different types at clinics, for example, for free. Counselling is another key thing. So, you know, counsellors are available, but, you know, the next step up would be health advisors or psychologists, and that being readily available. Mental health is having a massive impact, I think, you know, everyone at the moment, I think, with COVID, but, you know, if you think about HIV, but I'm sure also with TB, you know, the psychosocial aspects of HIV has an impact on, you know, somebody's mental health. So we need to get that side of things right, from simple counselling to psychology input around HIV to full-on mental health services as well. And I think, you know, two other points that are really around community. So I think community engagement, community support, and that includes peer support workers, is really crucial. You know, you can have a doctor telling you you're going to be fine, and, you know, you can have treatment, you know, you can live a normal, healthy life, you can have grandchildren, you can have kids, but hearing that from somebody who's HIV positive and lived through it is a different, you know, there's a different level of support there, or understanding.
No, I think it's so critical. You've raised some of those more holistic aspects as well, in terms of the accessibility of counselling, health advisors, and really promoting community engagement, and also a holistic approach to the care that you provide people who have HIV. The one question came up on the audience, and I think it resonates with some of what you've talked about here when you were talking about condoms and guarding against.
Yeah.
And the question was, what lessons have we learned from pre-exposure prophylaxis? And the excuse my pronunciation there, to apologise to you all. But the real critical question, I think, is at the end. Is there a difference in terms of adherence between high-risk groups or not in your opinion?
Yes. So PrEP has been studied for some years now. So it's pre-exposure prophylaxis. So it's almost like your contraceptive. So your family planning, your pill equivalent for HIV. So, you know, whereas a woman might take the progesterone pill or contraceptive pill to prevent pregnancy, HIV pills can be taken to prevent HIV. And essentially, you know, there's been multiple studies done, and adherence has been seen differently within those studies. So the studies that have had lower rates of success have very much been related to adherence. It has been in women, actually, that we've seen that, and adherence has been higher in men who have sex with men. So you know, that high risk group. So we do see a difference in adherence, and there are different options for taking PrEP as well. So PrEP is that you can take it as a single tablet every day, or there's a regimen where you can take it on demand. So on demand obviously means you need to know when you're having sex and be able to predict that. But most people, I think, opt for the daily tablet. But adherence is crucial to get the levels up. But the studies have actually shown a different level of adherence in high-risk groups.
Thank you very much, Nadia. I think it's important to provide us with this broader context, and I didn't mean to interject there.
No,
mindful of our time. We've got 15 minutes or so that we can get through some of these questions, and some really important questions here asked. And I'll leave this one open for Amina and Tom. If the mRNA vaccine were developed for TB, which antigens should be targeted? Tom, is that one that you can possibly answer? I think you may be on mute, and Amina, you might be on mute as well.
That's not really for me, to be honest, Theo, in terms of the antigens for TB. I mean, there are antigens in the different experimental vaccines that have been tested, including the ones that haven't worked so well. So I guess there's a range of antigens available, but no, that's not my particular area.
Thank you, Tom. Over to you, Amina, please.
Yes, no, I don't know too much about antigens. I'm a therapeutic specialist in TB, but there are various vaccine groups who are doing trials in vaccines, and I just wish them luck. I mean, we badly need a vaccine for TB.
Appreciate it. Thank you, Amina. Well, I'm gonna stay with you because there's another question which has been addressed directly to you, and what aspects of multi-drug resistance for TB treatment should be reinforced during the present pandemic or indeed future health crises?
You see, here again, multi-drug resistance in TB is a lot talked about. And there's a lot of funding that is directed towards multi-drug resistance. And there are a lot of new molecules on the market to treat multi-drug resistance in TB. But multi-drug resistance in TB is around 5% of the global problem. So I prefer to concentrate on drug-susceptible TB, because that is 95% of the global problem. And that is a transmissible variety of TB. So my clinical trials are all concerned with drug-susceptible tuberculosis. That's not to say we should ignore multi-drug, because once they develop drug resistance, it's practically a death sentence. But it's very expensive to treat people with multi-drug resistance. So I think I would prefer to concentrate on how to eliminate drug-susceptible TB so they don't eventually become drug resistant.
Mm-hmm. Thank you. I think an important answer there was considering how we allocate resources, especially when they are limited in this case. And I think useful to follow on once more, Amina, and just to ask you simply because I know you've got experience in trials in Latin America and in Africa and in South Asia, but which country has the highest incidence of TB at the moment?
Well, the highest incidence of TB is in China, in India, and in sub-Saharan Africa. Those also some of the republics of the ex-Soviet Union. But there is where you find multi-drug resistance in those hotspots in the ex-republics of the Soviet Union, because the drug-susceptible cases were badly treated, and so the patients developed drug resistance. But the highest incidence of TB, which was a question, is India and China and sub-Saharan Africa.
Thank you for clarifying. Tom, please follow on.
Well, just to jump in, Theo, about multi-drug resistant TB. I mean, it is heartening because, as Amina mentioned, there are some new drugs on the market to treat multi-drug resistant TB, in particular one called bedaquiline. There's another new one called pretomanid. So there is quite a bit of advance being made for the treatment of MDR and so-called XDR, extremely drug-resistant TB. You know, and a trial in South Africa combining this bedaquiline and pretomanid and a drug called linezolid, giving really very, very good results in a relatively short time compared to the traditional, very complicated, very long duration treatments that have been tried in multi-drug resistant TB up till now. So there are particular drugs that could, you know, wider access to those particular drugs could make a difference for MDR and XDR TB into the future.
Thank you, Tom. And I suppose if I may hold with you as well, there's an excellent question that's been asked. I'm going to try and make it digestible here, but because COVID-19 has highlighted so many of the comorbidities that indeed expose people to being at higher risk, and this is common for the diseases which we've also discussed here today in terms of people's I suppose ability to be able to either be treated or indeed go forward. But has considering these neglected diseases, considering that COVID-19 has shone a light on these comorbidities, do you believe that there will be a greater number of fatalities rather than those surviving from COVID? Do you think that there's going to be a change in our understanding?
Sorry, how do you mean? Sorry, Theo, I'm not sure.
Sure. So because of the benefits of the vaccine, so I should probably give it the full question here. Do you think with the total focus of COVID-19 has been reduced as a result of the benefits of the vaccine being realized?
Yeah. Well, I mean, I think everyone's aware that rolling out vaccines across the world is going to be a massive challenge. I mean, so you know, I think it's too early to celebrate the end of COVID because of the excellent vaccine results. I mean, we've got to implement it. We've got to roll that out, and not just in rich resource, well-resourced settings like our own, relatively speaking, but across the world. So I don't think it's premature to call for the end the end of the COVID problem. So I don't think that we're going to lose focus on other aspects of care quite yet.
Appreciate. Thank you very much, Tom. And I suppose following on here, Amina, and I suppose a related point that Tom's highlighting there, that it's not necessarily going to be the case that we will once get over this virus just because of the vaccine, but also there has been a greater attention to infectious diseases as a result of COVID-19, broadly speaking. But do you feel that the constant refrain, you could say, in terms of resources put into TB might awaken governments into making greater efforts to reduce or refine the regulatory restrictions and provide more resources to promote research in that area and other neglected diseases? Amina.
I can only hope so. Governments tend to focus on the current catastrophe, if you wish. Quite rightly, I have nothing against that. And the current catastrophe is coronavirus. Not so long ago, it was the Ebola virus, and then the SARS virus and the MERS virus. So I'm sad to say TB does get pushed aside and forgotten, pushed into the background and forgotten. And we have to keep reminding people that this disease has been with us for centuries. Really, we should have eradicated it decades ago, and we should put more resources into doing just that, and hope that somebody will listen. But you know, when you in the face of an massive earthquake in Kathmandu or somewhere, I'm afraid TB stands a poor chance. Having said that, I do think that with reduced treatment duration, which looks very likely in the near future, we can move towards eradication of TB. And that's where I would need support from donors. World Without TB would need support for funding for trials, and also from the regulatory bodies to facilitate these trials to take place. At the moment, we're trying to shift a batch of drugs from Guinea to Uganda, and it's taking us weeks to get permission from the Ugandan authorities. You see, that's where it's not going to be difficult to eradicate tuberculosis. We have the drugs, but it's these side issues that prevent it, and we should get over these.
Thank you very much, Amina. And I think it just reiterates some of the points you had made earlier and why it's so critical that more attention is spent here. We've got limited time available, but I do want to just bring it back to you, Nadia, for the question that's arisen anonymously, but in the early years of HIV and AIDS, response saw poorer countries significantly impacted due to the intellectual property rights, patents that is, that restricted the distribution of the drug. Today, some nations have called on the WTO for a temporary suspension on patents relating to COVID-19 vaccines. What lessons can governments and companies learn from the AIDS response in the past, and what more can be done to ensure equal access to treatment?
So I think it's a really good question to have brought up. So with the patents with HIV drugs that we have, I think pretty much, not all of the drugs, but the most commonly used ones are now off patent, and there's generic versions which are much cheaper. So I think definitely the lessons that can be learned from that. I think I don't want to say it's limited, but I think the process is limited as to how to sort of remove the patent. But there's definitely been a lot of lobbying. I know MSF, so Médecins Sans Frontières, have been very vocal with trying to do that and get the patents off. I think within sort of the HIV arena, there's a lot of patient activists, medical professional activists as well. So I think it's about really raising the profile and raising the dialogue and the discussion around it. I don't think, or I hope not, that the COVID vaccine would become patented in that way, given the pandemic situation, that it's an emergency situation. So I think it's sort of a slightly different, but it's I would say really it's around you sort of lobbying governments, or raising that profile and discussing it on an open platform. I've seen wonderful talks at conferences around the cost of, for example, hepatitis C treatment, which is astronomical, and it's really through that people do eventually things change. But I think there are some restrictions from that. But equal access, Tom's also mentioned that we do need to just make sure that all countries are, but I think it's sort of raising that awareness, but in some ways it is difficult, unfortunately.
Thank you very much, and indeed a difficult challenge for us to consider, and we're just running toward the end of the clock here, and I apologize for any questions that we weren't able to ask, but the last question that does stand maybe is an important one for us all to consider anyway in these closing remarks, and that is concerning the optimal use of public health messaging in order to reduce the prevalence and incidence rates for these infectious diseases that we've discussed today, and these diseases which we've discussed. So if I can ask you to provide a closing comment, each of you, and also if indeed you have any advice to Cov360, which is very much a volunteer-led global organization made up of 45 volunteers around the globe who really are trying to advance education and advance understanding and that appreciation for how maybe we can improve public health communication. Nadia, if I turn to you first for that.
Yep. So, I mean, I guess where do you start? But I know I'll keep it brief. I think some of the things I've touched on with the second question you'd asked, but I think if I was to really go for key things, it's about engaging the community, engaging, peers, people that have maybe, for example, I suppose with COVID, but also, equally with HIV, is getting them involved, because they're the ones that are really living through it. So I think that's, really a crucial way to get community messages out there. I think the other thing, and I don't want to say I'm a social media fan, but I think, with the times and with the way things are going, social media is something that we should use. And I think particularly for younger people, we do need to be thinking about those mediums, and having ways that in which it is a bit more snazzier messages, if you like. So I think crucially it's about community and making sure that you've got those community connections, getting patient reps, patients at the ground level involved with those messages. And I don't hate to say it, but social media is another thing that I think we should be utilising. I think on the notes of sort of something closing with regards to HIV, it's really to say that, yes, we have made great advancements, we really have, but, not to sound too cliched, but, we still have a big battle ahead in various regions, but also, just generally to really get it down to, zero transmissions, because we do have that, we do know we can get down to zero transmissions of HIV. And I think particularly with lower middle income countries, a point that I wanted to make earlier, but I think it's something I really do feel passionate about, and we've all touched on funding and resources. The services in those lower middle income countries really are overstretched and overburdened. And I think, resources need to be poured into those services to increase the access of drugs, the various drugs that are available, which are barely available in some countries. Tom's spoken about the changes within Cryptococcal Meningitis, but also to support staff. Staff on the ground are becoming burnt out, becoming stressed with their work because they're so overburdened. So I think we need to be pouring resources there as well. And don't forget, U equals U. So sorry, I needed to say that as well. So if you're undetectable, you won't transmit HIV. Thank you.
Thank you very much. I think it's an important point. I like the point you make as well concerning community leaders and their engagement. Indeed, not related to the neglected diseases we're discussing today, but yesterday the public health team met with Bay Martina from the Health Ministry in Cameroon, discuss how community leaders are so significant in their fight against malaria in the country. Tom, can I bring it over to you to offer your final concluding remarks and indeed any advice you've got for our young organisation?
Well, I was just going to stress in terms of reflecting on the effect and opportunities highlighted by COVID. That it would be marvelous if we could increase the degree to which we collaborate and coordinate our efforts, in large, simple trials to meet, not just infectious diseases, but other medical challenges. If you reflect on the huge progress and the important contribution that the UK's made in terms of therapeutics for COVID through that type of coordination. And, the only thing I think you have to consider, if you do have that type of coordination, inevitably it means a bit more of a kind of a top-down approach. So I think it's important also to have in place very careful governance of the direction. You don't want the whole effort to be in the hands of a very small group of people without proper kind of governance issues to take account of, because you've got to make choices about treatments to be tested and so forth. But I think there is a huge opportunity for more cooperation and more collaboration to speed progress to tackle these challenges across the board in medicine.
Thank you. I think that's a tremendous point to highlight the lessons we can learn from coordination, and indeed the huge opportunity that provides through us experiencing what's happened in this recent pandemic, what is happening indeed. Amina, I'm going to turn to you last, and thank you again for collaborating with Cov360, with your organisation, World Without TB, and offer you the opportunity to offer your final concluding remark.
TB, unlike coronavirus and HIV, TB is a poverty-related disease. It is the archetypal poverty-related disease. And until we can improve the economic situation of these people, we have to concentrate on finding an effective vaccine, but we do have an effective treatment. And we need to pursue that with everything that we have. The reduction, we've got new molecules on the field. The reduction of treatment duration is the one thing that we can tangibly do, reduce it substantially, so that adherence increases, cure rates increase, and one day we can have a world without TB.
Thank you very much, Amina. It's a pleasure. And thank you, Nadia. Thank you, Tom, for coming together today. It's been a tremendous conversation, and I think we've all learned a huge amount concerning HIV, cryptococcal meningitis, and TB, and to realize that COVID-19 does spark an opportunity for us to really push forward and pay greater attention to global health, the health inequities, which are highlighted by Amina's final comment there. If these diseases are prevalent in poverty-stricken countries, then there is lots to consider in terms of how we can improve health globally. And thank you again. It's been a tremendous pleasure. And I lastly just want to again highlight, thank you to our volunteers for putting all the effort they have into Cov360 this year. This may be our last event, so it's an opportunity to say live that we've been brilliant in terms of bringing this forward and having such an extraordinary pleasure to entertain such guests as Professor Jindani, Professor Harrison, and Dr. Ahmed. So have a great evening, everyone, and thank you very much. Goodbye.
Thank you very much indeed.
Thank you. Thanks. Bye-bye.